Thank you, everyone, for joining us tonight. The Promise team is trying something new. So we are introducing a series of short webinars on a single topic based on your feedback. And so this is our first one, and we are thrilled today to learn more about PARP inhibitors in prostate cancer treatment. My name is Christina Tran. I am your host tonight, as well as the Promise Registry Project Manager. And so we hope you guys will enjoy today's presentation. We will also be having a Q&A session right after the presentation. So we do ask that you please save your questions for that Q&A session. We would love to hear your feedback on this webinar so we can continue to host webinars on topics you're interested in the best way that we can. So we will be sending a survey at the end of the webinar for your feedback and would appreciate any thoughts you'd like to share with us. All right, and so we will get started. I'll first start by introducing our speakers for tonight. So first, Heather Chang will be speaking, and she is one of our Promise co-principal investigators leading the study. She is currently the director of the Prostate Cancer Genetics Clinic and associate professor within the Clinical Research Division at the Fred Hutchinson Cancer Center. She is also an associate professor in the Division of Medical Oncology at the University of Washington. An expert in prostate cancer genetics, she is studying methods to use genetics to guide the care of prostate cancer patients and their family members who may also be at risk for the disease. Our second speaker tonight is Channing Paller. Channing Paller is one of our Promise co-principal investigators leading the study and the director of the Prostate Cancer Clinical Research and an associate professor of oncology at the Johns Hopkins University School of Medicine. Her expertise lies in biomarkers that enable patient-centered treatment strategies. Dr. Paller's research focuses on developing improved targeted treatments to extend survival and improve the quality of life for prostate cancer patients. All right. And so now I will turn it over to Dr. Chang.
Well, hello, everyone. It's such a pleasure. And look, we got up to 100 participants. This is really, really exciting. So thanks so much for your attention. And all right, so we're going to talk by I think your request as participants about PARP inhibitors in prostate cancer. So let's go to the next slide, please. So here's an outline. We're going to talk about what are PARP inhibitors and then some of the current treatment options. And then probably what most of you are interested in is some of the updated results from recent clinical trials. And then we'll wrap up with some Q&A. Hopefully we'll have time. Okay, next slide, please. All right, so what are PARP inhibitors? Okay, so I like to show this slide. It's a little bit complicated, but PARP inhibitors are essentially a class of drugs that block cancer cells from a particular type of repair of mistakes within the DNA. So shown there is kind of a double helix or kind of double spiral, which is a cartoon rendering of what DNA looks like. And there's different types of mistakes that can happen. So this is like your blueprints of your DNA. All of us have this in all of the cells of our body. And this tells us, this is like the master blueprints of what makes you you. And it's really important for every cell division for those blueprints to be copied faithfully, that there's not mistakes that get made in order for the next cell, the daughter cells, to continue to do what they need to do in their important bodily functions. And so along the top is different types of mistakes that can occur, and mistakes are natural processes. And so, if you think about like in a factory, mistakes happen. Sometimes they're machine mistakes and sometimes they're human mistakes, but they're just a part of life, and we should expect them, right? And so in our system, our bodies have natural teams of genes whose job it is to find mistakes and correct the mistakes in order to ensure that the DNA that gets copied in the sort of daughter cells and the progeny cells, the kid cells, are faithfully sort of copied, and that there's not any more mistakes. That it's what I call the quality control team. So there's different types of mistakes along the top, and along the bottom of that double helix is the teams of genes whose job it is to find mistakes and correct those mistakes. And so just calling out two categories. One, on the very left-hand side is basic excision repair, and you can see PARP 1 along with XRCC2 or XRCC1 and ligase 3. We're not going to talk about those. We're going to talk about PARP and PARP. And then along the middle is homologous recombination. So genes that we've talked about a lot that many of you may be familiar with. Some of you may also have variants in these genes: BRCA1, BRCA2, PALB2, ATM, CHEK1, CHEK2, RAD51. So that's a family of genes that are important for correction of mistakes of in using a particular pathway. So a simple way of thinking about it is there are different teams that have different expertise, and they're looking for different types of mistakes, and then they find them and correct them. So they all work together. There's 6 teams, let's say the BER, the homologous recombination, NEHJ, NER, mismatch repair, direct reversal. So all of these are quality controlled gene families. If you have one of these taken out, all the other ones kind of rise up and say, okay, I can compensate. But let's say you have a cancer that is missing BRCA2 function, then it's really reliant more on the other 5 genes, the other 5 teams of genes, right? It's sort of like one critical team is out, so the others have to kind of step in and pick up the slack. And so when you get a PARP inhibitor and you have a drug that blocks a second team, that's too many teams that are out, and the system can't correct all the mistakes. And so what that results in a concept called synthetic lethality, where the cancer cell then has too many errors and basically kind of withers away and dies because it can't compensate. It has too many mistakes and too many errors in its DNA that it can't actually survive. And so that's what PARP inhibitors are. That's a little bit of an oversimplification, but the concept is generally you're taking advantage of the weakness of the cancer. The healthy cells have a functioning, let's say, BRCA2. So the healthy cell, the non-cancer cell, can compensate if you block PARP1, PARP2. But the cancer cells that are missing the BRCA2 or the PALB2 or may have a harder time compensating, and so they are more likely to be negatively impacted and die. So that's a good thing, right? Because we want the cancer cells to be dying and the healthy cells to be maintained. So that's kind of an overview. We can go to the next slide. So we've been able in prostate cancer to leverage the fact that PARP inhibitors have been in development as a class of drugs for oncology or cancer, but they had previously been used and approved in patients with breast cancer and ovarian cancer. And they've actually been around a little bit, since 2014. And so these are some of the approvals in breast cancer, but these drugs have also been used in ovarian cancer. And now they're being also used in pancreatic cancer as well. But the point is that we knew about these drugs, but they hadn't until recently been used in prostate cancer. But they certainly are coming onto the scene, which is really exciting. And we'll talk about them next. So let's go to the next slide. Okay, so current treatment options. So that's kind of the background to lead us into PARP inhibitors. Here are the 3 that are furthest along in the process, 2 of which have a FDA approval and 1 of which is breakthrough. So olaparib is also called Lynparza, and it was FDA approved for metastatic castration-resistant prostate cancer in May of 2020. And it has a larger gene list. So the HRR gene mutations, probably Dr. Paller is going to talk about this next. And then rucaparib is approved for patients who have prostate cancer, metastatic castration-resistant prostate cancer that has BRCA1 or BRCA2, either germline, which is inherited, or existing in the tumor only, which is somatic. And so that's the rucaparib approval. And then niraparib has breakthrough designation. That's another, basically they're all cousins. Another PARP inhibitor, breakthrough designation for metastatic castration-resistant prostate cancer. Actually, that breakthrough designation was in October of 2019, so happened actually before the other FDA approval. So that's really exciting. And then there's more actually that Dr. Peller is going to talk about. There's another one, talazoparib, that's also that was recently reported. And so the point is that right now it's available mostly in the late stage, again, metastatic castration-resistant prostate cancer. Those of you in the audience, some of you may have localized disease, or you're too early, or that's not quite appropriate for you yet, but it might be in your toolbox for the future. So you might be in an earlier disease point. Hopefully you might never need some of these drugs, but they're being studied, and we're pretty excited about using them and trying to figure out how to use them better. I think we can probably go to the next slide. And I think I'm going to hand it off to Dr. Paller to talk about some of the exciting results.
Thank you, Dr. Shang. That was really wonderful. I am thrilled to take you through a series, so it'll be about 10 slides of the highlights that you guys requested from about 2 weeks ago at Genitourinary ASCO, where on February 16th, it was really exciting. They presented a series of trials focused on PARP inhibitors. So let's start. So PROPEL. This was a trial of olaparib for metastatic castration-resistant prostate cancer. And here they compared a combination of abiraterone and olaparib versus abiraterone alone. So far we know there's improved overall survival versus abiraterone alone. We know there's radiographic progression-free survival versus abiraterone alone. And we also know there's no decrease in quality of life with added olaparib. For all comers. So let's go to the next slide and look at this a little bit more carefully, because I think pictures tell us a lot more sometimes. So here, the subgroups are broken down, although I'll show you on the next slide, there's a trend towards overall survival benefit across both subgroups. What's really key to see here is the take-home message from all of these trials is that you can see the mutated patients or patients with variants on the left, and the patients without variants or all comers on the right. And you can see a much bigger difference on the left with a hazard ratio of 0.6. Oh, 6.6, I need glasses now, and 0.89 on the right. And I point this out to you because it's really key across all of these trials that we're really seeing an impressive response in patients with these HRR mutations. All right, next slide. So here we see PROPEL, the overall survival of the final pre-specified analysis, and you can see the hazard ratio is 0.8, the p-value is 0.05, the confidence interval does not cross 1. All these things mean that there was a significant difference in the total population of 7.4 months. But I'm a bit of a skeptic, and that's why I showed you sort of the breakout first, because I think the majority of that benefit is really coming from the patients with mutated variants. Next slide. So the side effects, here you can see the difference. Again, the common side effects are anemia or low red blood cell count, fatigue, some nausea, back pain, diarrhea, but they were not significantly increased compared to Abi alone, which was good news for patients. Next slide. So let's talk about another one of the trials that was presented. So Triton 3 was about rucaparib versus physician's choice in patients with a BRCA or ATM mutation. And physician's choice in this case was either abiraterone, enzalutamide, or docetaxel. And so far what we know is that radiographic progression-free survival is improved with rucaparib in these patients. But now again, let's look at the curves. Next slide. So if you break it down and you look at the BRCA subgroup, the other big takeaway is that BRCA is king in terms of response. So you can see here, there's a large difference with a hazard ratio of 0.5 in the BRCA subgroup for rucaparib over physician's choice. In the ATM subgroup, this difference really disappears. I would like to point out that right now, this is consistent with other trials where we see that ATM does not respond as well to PARP inhibitors. And we would pick something else. We would pick probably chemotherapy for an ATM patient, or we would pick a clinical trial. There's several clinical trials out there targeted. I can think of Planet. It's open at many sites around the country for targeted therapies for ATM patients. And so I would recommend those patients potentially getting a second opinion. Next slide. All right, so let's talk for a minute about magnitude. This is looking at niraparib with abiraterone in metastatic castration-resistant prostate cancer in patients with HRR gene alterations. So they compared niraparib with Abi versus Abi alone, and prednisone is always given with Abi. So far we know that there's radiographic progression-free survival versus Abi alone. Next slide. And you can see on the left, radiographic progression-free survival, and on the right, time to symptomatic progression, and both show a significant difference, which is great. I do want to say that we always like to wait for overall survival, but we're still, this trials and studies immature. So next slide. We don't yet see that big separation of the curves that we're hoping for, but you do see that the green curve or the combination arm is starting to separate. And so we'll look forward to further results down the line. Next slide. All right, TALAPRO-2. This is talazoparib with enzalutamide in metastatic prostate cancer. Remember, it's not yet used to treat prostate cancer. And what we've seen so far is there is improved disease and PSA progression-free survival. So more to come on overall survival. So let's look more closely at those curves again. And here you can see the radiographic progression-free survival. There's a nice separation of those curves. And you can see there's a benefit from the combination. Next slide. All right, so in summary, we have PARP inhibitors that are known to block cancer cells from repairing tumor DNA. And we have 3 drugs that are approved. And we have a lot of results from clinical trials, and we hope for more in the future. And we are excited to work with all of you. Next slide. All right, Q&A. I'm really excited that you're all here and to answer some of the questions that have been sent in.
All right, thank you so much, Dr. Paller and Dr. Chang. That was terrific. And so we'll move on to Q&A. Before we start, I just wanted to introduce you all to our wonderful clinical research coordinator on the call with us today. Her name is Stormy Smith, and she has been with us since August 2022. We really couldn't do this without her, and she'll be helping to field some of the questions that you send to us today. So feel free to start typing in your questions to the QA panel at the bottom of your screen, and we will start with a few of these. So I see a question here that asked, do you think that any of the PARP inhibitors being used as a treatment for earlier stages for prostate cancer? So let me just re-ask that to be a little clearer. Do you see any of the PARP inhibitors being used as a treatment for earlier stages of prostate cancer? So that question go out to either Dr. Paller or Dr. Chang.
Well, I think the exciting thing is that there are ongoing trials in earlier disease spaces. So I think that the question actually called out hormone-sensitive prostate cancer, and so there's a trial called Amplitude that is in the hormone-sensitive space and others. And then Dr. Paller, actually, I'll let you talk about. We have one that's with PARP inhibitors and biochemical recurrence, but I think they are getting moved in clinical trials in earlier disease states, and that's part of what's exciting about our work together.
Absolutely. I have many very happy patients who are in biochemical recurrence. So they had surgery or radiation and their PSA is rising, but they wanted to avoid hormonal therapy and they have a mutation and they've done well on PARP inhibitors. So I am excited that we are trying this in clinical trials, but we still need to learn more.
Great. Thank you both. Another question I see here is if PARP inhibitors block a second pathway, can they be used for existing mismatch repair mutations or only with HRR mutations?
Yeah, I think, maybe I'll try to answer that. I think the data from breast and ovarian cancer is that PARP inhibitors work best. They were kind of designed for cancers that have a predominance of BRCA1, BRCA2, and kind of the homologous recombination DNA repair pathway defects. That's where they were sort of originally conceived, and that's where they had their what appears to be the best performance. For mismatch repair, actually, we didn't talk about it today. We can talk about it at another time. Those cancers actually seem to respond better to immune checkpoint inhibitors like pembrolizumab. So, your question is a reasonable one, but I think that's a bit of an oversimplification. There's probably more to it, but PARP inhibitors at the present time seem to have their best performance characteristic when there is a defect in homologous recombination as opposed to mismatch repair.
Great. Thank you so much, Dr. Chang. Another question we have here. So can you talk a little bit about how talazoparib, rucaparib, and niraparib compared to each other?
I don't know, Dr. Paller, do you want to take that one or?
I don't like to compare them without a direct comparison, even when my curves say something. So I'll let you comment on that.
Yeah, I don't think we have enough experience for prostate cancer patients in a head-to-head comparison. So it's a little bit difficult to really, say. I think they probably do have different subtleties to them, same as, enzalutamide, darolutamide, and apalutamide, for example, would be an analogy. So at the present time, they all have that basic function, but, as we study them further, we're probably going to observe some differences.
Yeah, they're mechanistically slightly different is exactly right. So I would agree with that, but whether it plays out clinically is still to be seen.
Great, thank you both. There's another question here. So how would you manage side effects for PARP inhibitors? And can you talk a little bit about what side effects that someone might expect?
Sure. So some patients tolerate it like they don't even know they're taking medicine, which is always really exciting. And some patients really struggle, right? They have some nausea and they need some anti-nausea medicine, or they develop anemia and we have to hold the drug for a period of time or even lower the dose. A small percentage of patients even needed transfusions during the trial. And so there's different ways, but we continue to support patients, or if they develop high blood pressure, we treat their blood pressure. But sort of fatigue, they can take naps, but if it's really inhibiting their quality of life, we like to lower the dose to find a tolerable dose. Really, this is to help you live well with your cancer, is the goal here.
Great. Thank you, Dr. Paller. So there's another question here. We actually have a few asking if we believe that PARP inhibitors may be eventually used for individuals who don't have genetic mutations.
I guess I can start. There's some new data that actually Dr. Pellin and I just saw that was reported out, or actually she showed a slide from Propel, and then Talipro. There are studies now combining AR targeting drugs like enzalutamide or abiraterone with PARP inhibitors. And when you look at the population of patients that include both carriers and non-carriers, and different studies have designed their trials differently, like Magnitude, I think, probably, in my opinion, was a cleaner design because they upfront tried to sort out who had mutations and who didn't. And in other studies, they sort of looked at it after the fact rather than sort of in a proactive fashion. And it looks like there may be some benefit for all comers, as Dr. Paller was saying, but we do know that the biggest benefit is clearly in the people who have BRCA2 and that's and genes like PALB2 and probably CHEK2. But those are the things that we want to learn together with PROMISE, is those nuances, because the numbers in any one of those studies are not going to be as big as the numbers that we can assemble together in PROMISE, right? So,
and I will admit, I could be wrong, but I'm a bit of a skeptic. And so I'm really grateful that we're doing registries like this so that we can look and see if really it's just mutations we haven't discovered yet, right? Why are those people responding and who are they and how are they special? So I can't wait to learn.
Yeah, and I think just to add to what Dr. Paller was saying, it's the side effects for some people is no big deal, but for other people, it is a big deal. And if it's a big deal, then we want to make sure that they're going to actually get the benefit. So I think, if the benefit is less pronounced, then it's not as easy to say this is the right thing to do if it's difficult for them. But I think those are all things that we're going to kind of learn together as we move forward.
Great. Thank you both so much. We're going to do 2 more questions and then close out the Q&A for today. I apologize, we can't get to all of the wonderful questions that we have here, but hopefully, these are representative of what you guys have sent in today. So one of our last questions here is, do we think that PARP inhibitors would be a good treatment option for individuals who have mutations aside from BRCA1 and 2? So what about ATM and PALB2 or other mutations?
So for ATM, we are consistently learning that we would pick something probably besides a PARP inhibitor because those curves don't separate. If several of the trials that I shared there was not a benefit for the ATM patients. And so really I would suggest chemotherapy or a different option or a trial targeting an ATM for the mutation for those patients. For PALB2 and other mutations, that's what this is all about. We are still learning. We are really excited. We are eager to learn together what will work and what won't work in these smaller, rare populations. Heather, do you want to add to that?
Yeah, I mean, I think the one that we are, as you say, ATM is one that doesn't seem like it's respond. So I think the answer to that is we need better trials for ATM patients, right? So, so it's not to say this is the end of the story by any means, but we just need to do better, and we can, and we are working on, and the field is working on it. I want to just maybe, I'm looking at the questions. I think we can answer some of them pretty quickly. And sorry, I apologize. I didn't say how are PARP inhibitors administered. They're oral, they're pills. And we use them if they work, as long as they are working and not causing any problems. And they, let me see, I think that there's a question about side effects. I think working with your doctor on side effects, but if there are sudden severe side effects, that certainly warrants attention.
Great.
The drug costs can be variable, highly variable, depending on the copay. They can be expensive depending on the kind of insurance structure and whether there's patient assistance that's available.
So I'm going to teach this very intelligent group with very great questions one skill. If you go to Google and type in clinicaltrials.gov, many of these questions about is there a trial about this can be answered simply by putting your keywords in the keyword box. So if you type in, for example, Pluvicto, PARP, prostate cancer, up will pop whether the trial I'm thinking of is open and if it's near you. And so that is a good tool to learn how to use, and I'll happy to post that on our website to help with that. Thank you, Christina.
Of course. Thank you both. All right. So I think with that, we will close out our Q&A. We just want to say thank you so much to everyone who joined us today. We hope you enjoyed our webinar and hope that you learned something helpful today. And so we will be sending out the recording of this webinar along with the recording of our annual webinar we had earlier last year. So you can watch both at any time. And so we'd love to hear from you. So definitely when you get the survey after this webinar, please do share any feedback that you have. We'd love to learn how we can improve, and we'd love to learn what other topics you might be interested in for the future. And so I also want to thank our terrific speakers, Dr. Chang and Dr. Paller, as well as Stormy, for their support and organization of this webinar tonight. And thank you all today for joining us. And we really appreciate the fact that you are part of our Promise Coalition. And with your help, we can bring precision medicine to the fight against prostate cancer. Thank you all and have a nice evening.
Thanks so much.
Thank you. Have a good night.